Before we begin, the information provided is for general educational purposes only and is not intended as medical advice. It does not replace consultant with a qualified healthcare professional. If you have a medical concern, diagnosis, or treatment question, you should consult your physician or another licensed healthcare provider.
Hello, Dr. Hamilton. How are you doing?
I am great. Thanks for having me.
Thanks for being here. I was telling people earlier tonight that it's very fitting that we have you on this evening. This summer is going to be our first ever drumathon in Nashville. We've been coming to Nashville since about 2012, every year, once a year, to do something in the music community because it's so active and so wonderful there, and that community is so strong. And we're really excited to bring Drumathon there this summer and to be working with you and the Sarah Cannon Research Institute there in Nashville.
Well, we're not called Music City for nothing. So
I know, right?
We're looking forward to having Drumathon here.
That'll be awesome. I can't wait. We've got a lot of drummer friends there who are going to help us make it a beautiful, beautiful thing. So as we were talking about a little bit off camera there just for a few minutes, the main thing we want to talk about is kind of fill people in a little bit more about triple negative breast cancer. The thing that we've been talking about on the show primarily is that it's more rare, aggressive, affects about 10 to 15% of the women diagnosed with breast cancer, that it affects younger women, usually under the age of 50. It's more prevalent in Black women. Are there some other things you could tell us about triple negative breast cancer other than those things?
Yeah, I mean, I think you hit on a lot of them. It disproportionately affects young women. It disproportionately affects Black women. In fact, Black women are more than double as likely to get triple negative breast cancer than white women. And then Hispanic, Latino women are even less likely than white and Black women to get triple negative breast cancer. A lot of people ask me, why are Black women so much more likely to get triple negative breast cancer? And to be quite honest, we don't fully understand that. There's a lot of things at play. There's some socioeconomic things at play, stress, other comorbid conditions, obesity, access to healthcare. There are some genetic variants. There are some certain genes, BRCA1, that's more prevalent in African American ladies and their breast cancer. So there's a lot of things at play. But actually, that's one of the reasons that everyone finally got on board recommending mammograms younger at the age of 40, even the U.S. Preventative Services Task Force now, because it was recognized that particularly among young women, this was disproportionately affecting Black women being diagnosed before it was recommended to get mammograms. Triple negative was really kind of the dreaded type of breast cancer because there weren't as many targeted agents. We'll probably get into this, but we now do have an immunotherapy approval and some exciting new drugs on the horizon for triple negative breast cancer. But it is our more aggressive breast cancer, faster growing, more likely to be found, more advanced, et cetera.
You were talking about the BRCA gene. Is it true that if you have that gene or that makes you at higher risk of triple negative?
It is. Yeah, it's still true that most women won't have a BRCA alteration. A lot of people say, oh my gosh, why did I end up with breast cancer? I don't have the gene. And the reality is that most people diagnosed with breast cancer don't have the gene. But if you do have that gene, you're at a very high risk of breast cancer.
We were talking about this a little bit earlier, Erica, that there's so many more genes that they test for now than they did. Like when I was diagnosed in 2010, I swear it was like 4 or something. And then it was like 14 or 15. Then it was like 27. It was like 30 something. Now how many are we at? What's the amount of genes that they test for that relate back to breast cancer?
Yeah, it's quite a bit higher, and it depends on the panel you get. I mean, that's the other thing. There used to kind of be one panel that you got offered. There's quite a few vendors that offer these panels. In terms of the, penetrance of genes, meaning, when you have one of these gene alterations, how likely is it that you end up with a breast cancer? It's really BRCA1 and 2, and then PALB2, where it's really quite, common that you're going to end up with a breast cancer. There are other genes that definitely increase your risk, check, variation, et cetera. And then there are some other ones, like that are more common with colon cancer or some other cancers where, risk reducing surgery isn't recommended. You may only have, kind of, a modest increase compared to the average woman. It's not recommended that people go get prophylactic mastectomies, but your risk of breast cancer is a little bit higher than the average person. And so it depends on the panel that you get, but definitely many more genes that we know can increase breast cancer by a little bit. But those kind of, very high risk breast cancer genes really still are the BRCA1 and 2, as well as the PALB2 gene.
How often are they checking for new mutations? I mean, is it just something that you guys do every year, and then they just, or somebody does every year, and then they just add it to the list and they continue to check? Because I know, like for me and many others, like I see a lot of cancer on my dad's side of the family, so I know that there's some correlation there. But of course, I haven't had any mutation found yet.
Yeah, same with me. I have a lot of breast cancer on my side of the family, and there hasn't been a mutation either. Honestly, I think some of that actually comes from sequencing on the other side. We do a lot of NGS testing for patients that have metastatic disease, and so that's kind of more, whole genome sequencing of the cancer, looking for broad mutations within the cancer. We're talking about kind of sequencing somebody's normal cells of predisposition genes. But I think the helpful thing really is that we have so many patients that have had breast cancer in these databases now that they are pretty good about going back and looking. And when something kind of pops positive, we now have enough evidence to say that we think that this is linked. They go back and they actually update that. And these companies go back and actually contact patients. And so I think that's one of the advantages of going with, one of these reputable companies, not something that you kind of, get for $200 online, but, something that you get at your doctor's office is that they do go back and contact patients and say, hey, new information has come to light. We think that this gene is related to breast cancer, et cetera, and they update this. So, we've been doing this a long time. You're right. It has changed over time. My mom got BRCA testing, when I was in middle school, and a lot has changed since then. And so, we have gotten updated testing, and it does change over time.
I mean, all of it points back to, I know you were talking about that, even if you're found with one of these other genes, it doesn't necessarily mean that you need to do anything. You don't need to go run out and have a double mastectomy or anything like that. But it's always good to know your risk and to kind of have your pile of, okay, these are my risks, and then have your doctor know that so that you guys can be kind of monitoring things maybe a little bit more closely. Don't you think that's kind of the most important aspect of it?
Absolutely. I think it never hurts to be an educated consumer, right? There's also other things we can do, right? Being vigilant, that's one thing. The other thing is there's other screening modalities. So some people qualify for adding breast MRIs in addition to mammograms. A lot of times when we do breast MRI screenings for patients, we tend to stagger them. So we'll do an MRI. 6 months later, we'll do the mammogram. 6 months later, we'll do the MRI again. So, women that are at higher risk, they're getting a picture of their breasts every 6 months instead of once a year. Some women get ultrasounds in addition to mammograms, depending, particularly, women with higher breast density. So there's a lot of additional things we can do depending on patients' risk factors. And then also with these genes, sometimes it also comes with a risk of a cancer that's not just a breast cancer. So if you are at really high risk of a melanoma, I'd want to know that and be getting a full body skin check with dermatology. Or if I had an increased risk of colon cancer, then that may be that I need to have a colonoscopy more frequently than every 10 years. Maybe the recommendation is every 3 or every 5 years. And so knowing what your risk is, there might be something you can do to help protect yourself against that cancer or a change in your screening guidelines.
My brain just races with all kinds of things I want to talk about with you, Dr. Hamilton. I want to plug in real quick. Jen Roper is watching right now. She says, I don't know if my mom died by triple negative breast cancer in 1992. I don't even know who her doctors were, but I do not know the hospital where she died. Is it worth trying to dig down and research what type of breast cancer she died from, or should I be checked for a gene?
Yeah, so I would say that if she was diagnosed in 1992, that was long enough ago that even if she had some type of testing, that really would probably be considered an inadequate panel in this day and age in 2026. So I would probably just talk to your doctor about your risk factors. And if you have a high enough family history, just do testing yourself. I don't think there's probably going to be a whole lot of data that's good enough quality from back then to really be informative for her, other than just the fact that she had breast cancer.
Yeah, that was a really great question. I don't want to get too far off. I love talking about just breast cancer in general. There's one other thing I wanted to talk about regarding that. There are several things that are risk factors for breast cancer that you can't do anything about, and there's things that you can do something about. Could you go over those and the differences between the two?
Yeah, absolutely. So the things we can't do anything about. We can't do anything about our genetics, right? We There are things that we technically could do something about, but we may not really want to do something about. So how many children we have, what age we have children at. Whether we breastfeed or not. Those are all risk factors for breast cancer.
It's
Um,
sorry to interrupt you, but
but
I was talking to somebody about this earlier tonight. Breastfeeding. So if you don't ever breastfeed, does that make you at higher risk?
yes.
I thought that's what the deal was, but I wasn't sure. And I was asking her earlier. She did breastfeed, and then I mean she did get cancer, but I was curious about that. So it's so interesting. Keep going.
Yeah, having pregnancies and or both breastfeeding is protective against breast cancer. And having pregnancies earlier in life is protective compared to having pregnancies later in life. So if you wanted to have 14 children, that would be fantastic. That often doesn't fit into the rest of our life choices. So I wouldn't
Right.
advocate people going out and having 14 children unless that just really fits in with everything else you want to do.
Right.
But that would be protective against breast cancer.
That's so
Um,
funny.
so other things, body mass index, alcohol consumption, that's gotten a lot of talk recently. There is now no safe amount of alcohol. A lot of patients ask me about that. There's been a lot of data from the cardiovascular literature that kind of one alcoholic drink per day could actually be cardioprotective, especially a glass of red wine. In terms of the breast cancer literature, we can say that one glass of red wine a day is not particularly protective for breast cancer. There is not a safe amount of alcohol. We do know that the higher amount of alcohol is definitely worrisome, but really no alcohol is safe.
I
I think a lot of us choose to use that quite sparingly,
Right.
but that's the formal answer on that one.
Yeah, I could hear Dr. O'Shaughnessy saying it. She said it so many times. She's like, damages cells. Alcohol just damages cells. That's the way she puts it every time we talk about it. And I think that's so important for people to hear. I
And
mean,
I
people
can
hate to
tell
hear
you
it,
that Joyce and I have definitely had a glass of red wine together. So,
but
we all make our individual choices, but
yep.
yes.
Truth. You kind of glazed over body mass index. Can you talk a little bit more about that?
Yeah, that's in particular for ER positive breast cancer or hormonally driven breast cancer. Hormonally driven breast cancers are the most common cancers we see. That's about 70% of breast cancers. HER2 makes up about 15%, and triple negative makes up about 15%. So that kind of makes up for that other 30% that we're not talking about. But especially in postmenopausal women, our ovaries aren't making the estrogen anymore. So how we get estrogen in our body is a conversion of normal body steroids into estrogen through an enzyme called aromatase. Aromatase lives in our fat cells. And so the more fat we have, and so the higher body mass index we have, the more circulating estrogen we have. And so particularly having a higher body mass index can be a risk factor for breast cancer, and particularly a risk factor for breast cancer recurrence once you've had breast cancer. And so that's one of the most important things women can do to help prevent the risk of breast cancer once they've had hormone receptor positive breast cancer is maintain a normal body mass index.
Gotcha. I read something a couple of weeks ago. I don't know if it was correct, and maybe you can tell me, that said that in the United States, 40% of all diagnosed cancers are associated with being overweight or obesity. Does that sound about right to you?
Yes. Yep.
That's so crazy. And so the healthier the country, where you live, possibly, I know a lot of people tell me that they're like over in England, they have different eating regimen and there's not as much obesity there. And so the cancer rates are maybe lower and things like that. It's just crazy to think about.
It's true. I always kind of roll my eyes sometimes when I'm in France because it seems like all they do is drink red wine and eat cheese, and it seems like the best lifestyle ever. But then I also notice that I'm having to wear my tennis shoes and they walk everywhere. So I often tell my patients that it's not all about, what you're eating. It's also about your activity level. So, if you don't have the absolute healthiest diet or you really enjoy your food, then you've got to compensate for that with your exercise and your activity level. So, it's a trade-off, right?
Yep, so important. I know that every time I talk to Dr. O about anything to reduce risk, she says is for triple negative recurrence, especially. She's to say low fat diet, exercise, no alcohol, and keeping a healthy body weight. Those are like the things she always told me. She always said 30 minutes walking a day at a minimum type of thing. Like, you think that'd
the other
be easy,
thing
but
that
it's not.
the thing that I think it's really hard to put a finger on is stress levels. And I think that's such a buzzword. I mean, we all have stress, right? It's impossible to live without stress. But exercise is really good in terms of helping us sleep better at night. It's good for stress reduction. I mean, there's such great studies. And now we all have, Aura rings or something on our, wrist that's telling us how well we sleep. And I don't know about you guys, but, when you get exercise, the quality of your sleep at night really is so much better. And so I think exercise is good for us for a lot of reasons, not only cancer recurrence, but also the quality of, our stress and, recovery during the day and also our sleep at night as well.
Yep, totally good, totally good. It is something that people don't talk about enough. Really, is stress levels and how that can affect your overall health. So that's super important. We talked a little bit about some of the statistics having to do with triple negative breast cancer. The 10 to 15% of those diagnosed with breast cancer are triple negative. What are some other statistics you could tell us? Like, do you have some statistics on like stages that are most commonly diagnosed for triple negative, different things like that?
Yeah. So, I mean, the most important thing is when you're diagnosed in terms of, is it early and it hasn't gotten to the lymph nodes? Is it node positive or is it metastatic? Now, if we can catch triple negative breast cancer before it goes to the lymph nodes, the odds of survival at 5 years is in excess of 90%. Actually, quite good, right? If it has gone to the lymph nodes, 5 year survival is actually about 2/3 of patients. And that's really not that great compared to some other types of breast cancer. ER positive breast cancer is much better than that. And if we talk about metastatic breast cancer, where the cancer has spread outside of the breast and lymph nodes and is other places in the body, 5 year survival rates is actually less than 15%, which is really quite different than ER positive or even HER2 positive breast cancer, where we know even HER2 positive breast cancer survival rates at 5 years is in excess of 50%. So very dependent on stage. The other statistic, we mentioned before is around Black women. And we've already talked about the fact that Black women are more likely to have triple negative breast cancer. But even matched stage for stage, Black women are more likely to die of triple negative breast cancer than white women. And a lot of that has to do with racial inequalities to access to care. Not being offered the same therapies, not accessing the same level of healthcare, and then there's still some distrust in the healthcare system as well. So that's kind of a sobering statistic and a statistic that we need to do better about.
Yeah, that's so true. That's something we work with Parkland here in Dallas, and I know we're planning to work with, I think it's a Nashville General there in town for you, and trying to make a difference in that. I was on a webcast with them where they told me about that. It was just really shocking, and we really do need to do everything we can to change that number. I think it's very possible, and just getting that awareness out, and that's why I feel like these broadcasts are so super important. It's crazy though.
I completely agree. There's I participate in a lot of clinical trials. I'm very passionate about trials, but there's some misnomers even around clinical trials and Black patients. A lot of people feel like Black patients are more likely to be distrustful of clinical trials because of things that have happened in the past, et cetera. But our data actually shows that if you offer Black patients clinical trial, they are just as likely to participate on a clinical trial as white patients. And so if we have less patients entering clinical trials, that's because we're not offering it to them, not because they're not participating. And so really the onus on us is to offer it to them, sit down, answer all their questions, and really make sure that they feel comfortable with that trial.
Yeah, that's powerful stuff right there. I've got a question coming in from Amy right now. She says, even though I've asked a lot of times, my oncologist wouldn't give me statistics on stage 3C with lymph involvement and no PCR. Is there a way to find this out without their help?
Yeah, I'm not sure I can come up with that one off the back of my retinas.
Right.
Yeah, I think the problem is a lot of times what you find online is already a little bit outdated. Um, you know, um, Probably the latest publication is the Keynote trial, where we used kind of our TC to AC with pembrolizumab. A lot of times in those trial tables, you can find kind of breakdown by stage, and PCR, non-PCR, et cetera. Probably they're probably not trying to not tell you, but it just gets very granular when they're kind of talking about, the different stages, and then PCR, not PCR, that type of thing. But yeah, I think you can kind of search around and find that to a degree. It's hard because, when you have one patient sitting in front of you, the answer really is it's 0, it's 100%, right? Because you're either not going to relapse or you are. But I know a lot of people do want to kind of know that statistic of, what are the chances, right?
Yeah, I get it. It's a hard question to ask, and a hard one to answer too. You were talking a minute ago about like the how the different stages of triple negative breast cancer kind of are more aggressive and less likely to survive at the 5-year rate than other types of breast cancer. How does inflammatory breast cancer stack up to that?
Yeah, so inflammatory breast cancer is really challenging. Luckily, most of the breast cancers we see are not inflammatory. I think inflammatory, a lot of people don't really understand what that is. Inflammatory is a clinical diagnosis, meaning it's not something that, we can diagnose on a pathology slide, et cetera. It's really something that your doctor diagnoses when they see you in the exam room. And what it is a red, hot, swollen breast. It's when you can see that there's redness and swelling on the skin, and the cancer cells are involving the skin of the breast. So it's really a clinical diagnosis there. So what it is when the cancer cells have spread to the skin. One of the great tests in the clinic for me, sometimes people have some redness to the skin just because they, have a large tumor and that kind of skin isn't draining well, et cetera. But a lot of times, if you kind of lay somebody back and that, redness goes away, that's kind of, more like lymphedema, et cetera. If it doesn't, that's, actual redness in the skin from cancer. But what happens is it's very hard to kind of get rid of because the cancer kind of has its little fingers and it's spreading across the skin. And so a lot of times it gets a lot better during chemo. We do surgery. We think everything's great. You're radiating it. And then, right outside that radiation field, little nodules pop up and it just tends to come back on the chest wall. And so that's just a very locally aggressive type of cancer that tends to have a lot of problems on the chest wall with local recurrences, and tends to be tough to get rid of.
So if someone was to ask you, hey, is triple negative worse or more aggressive than inflammatory, would they be about the same? It's just a totally different. I get that they're just kind of totally different and that one's more internal, right?
Yeah, I mean, they're totally different. I mean, a lot of inflammatory cases are triple negative. We can also see HER2 that's inflammatory. Yeah, apples and oranges.
And it's funny that you said oranges because I hear a lot of people when they talk about inflammatory breast cancer, they say it looks like an orange peel,
Yes.
right?
Yes.
So
Yep.
it's kind of crazy. It's a good reminder to folks that are watching right now that if you see any changes in your breast, be sure to inform your doctor, even if it's like a visual change. Sometimes that might even be more important. Your nipple is
Yeah.
inverted or anything strange like that. Be sure to alert your doctor. All right, so we hit a bunch of statistics. We talked about what triple negative breast cancer is. You are involved in some great clinical research and trials going on right now. Can you tell us what the latest is and some success stories?
Yeah, absolutely. So I'll say maybe I'll kind of go one step back from the actual latest. I mean, I think one of the big improvements recently in triple negative breast cancer was immunotherapy. Before that, for triple negative, really we had chemotherapy. And that was really it. We didn't have targeted agents other than PARP inhibitors, which was for a small subset of triple negative breast cancer. Immunotherapy is really helping us cure more people, particularly in the early setting, and a subset of first-line metastatic patients that are eligible that have PD-L1 expression. But really, all the rage right now is around antibody drug conjugates. And what antibody drug conjugates are is it's a target, so it's an antibody with a linker where the chemo is attached to that linker. So when we infuse it in the body, it's IV like chemotherapy, but it floats around, not really doing anything until that antibody binds the cancer cell. And then the chemo is dropped right on the cancer cell and it leaves the healthy body alone, the cells. So you can think of it kind of as targeted chemotherapy, or some people call it the smart bomb. And so it's really
Nice.
targeted chemotherapy directly to the cancer cells. And we
Wow.
have several of them approved now in triple negative breast cancer. We were first in HER2 positive breast cancer, but we've heard about trastuzumab deruxtecan in HER2, that's for HER2 low. We've heard about Trodelvy, sacituzumab govitecan. That's a TROP2 targeting antibody drug conjugate. We also have datopotamab deruxtecan, Datraway. That's another TROP2 targeting antibody drug conjugate. So we have several of these now in triple negative breast cancer. Every trial we've seen read out with an antibody drug conjugate has beat standard chemotherapy. So I think it's really exciting. It's exciting not only because it works better, but they also tend to be a little bit friendlier than chemotherapy. Sometimes I think we oversell this. It's not a walk in the park. I mean, they still have a cytotoxic payload, but all in all, I think they do compare favorably to chemotherapy. So that's been really exciting. Those are all approved in the metastatic setting. We've now seen positive data with these in the first line metastatic setting. And these are in trials now in both the neoadjuvant and adjuvant setting. So in the curative setting, these are currently in clinical trials that are enrolling. So we're trying to bring these up to try to cure more patients now. So I
That's
think this is
amazing.
a spot that we're really going to see a lot of movement on, potentially being able to spare more patients naked chemotherapy, as I like to call it, in the curative setting. So expect updates there.
That's so cool. If somebody was interested in being a part of that trial, like one of the folks who I do our Mighty and Metastatic show with, Kimball, she's our bass player chick. She's metastatic, triple negative. How, if she wanted to get involved or if somebody wanted to get into one of those trials, how would they go about that?
Yeah, so I mean, there are trials in multiple institutions across the United States. The neoadjuvant trials are for people that are just diagnosed, haven't had any treatment, haven't had surgery. Most of the neoadjuvant trials are taking patients that are a little bit on the higher risk side. So you have to have either lymph node involvement or a tumor that's at least 2 centimeters. In the metastatic setting, it's really anyone. We've got trials that are first line. We've got trials that are for patients that have already had chemotherapy or already had an antibody drug conjugate. We've got new targets. We've got new payloads. I've got antibody drug conjugates in Nashville to B7H4, to Nectin. We've got all kinds of new targets and payloads. So I think there's, really a lot of opportunities in the metastatic setting. Right now, as it's always been for drug development, we tend to develop drugs in the metastatic setting. And then once they show themselves to be, very promising and typically have approvals in the metastatic setting, we start to kind of pull them up into the curative setting.
That is super exciting. And I know that people who are watching right now who are metastatic, triple negative, this is giving them probably some hope. And I know that Dr. O always talks about, sorry to keep referencing her a lot. It's my big reference point, but she told me about where you can go. Like there's like a government website where you can find the different trials. What is that website?
Yeah, that's clinicaltrials.gov. That tends to be a good jumping off point to at least kind of see what's out there. The challenge is a lot of times, it doesn't have all the inclusion, exclusion of kind of who qualifies. So you're not going to really be able to tell if you necessarily fit, but you can at least kind of see like in general who they're looking for and probably figure out like the sites of who has it and what may be your nearest site, and then give them a call and at least kind of figure out like, hey, is this worth maybe a visit?
Very cool. That's awesome. At least
The
it's
other
a
thing,
start.
honestly, that I would do is I would just go to a clinical trial site, go to whatever your nearest big clinical trial site is,
Right.
and then ask them, hey, what would be a good trial for me? And what's the nearest one to my house, like my home? I mean, all the time, I see somebody and I say, look, they have this at Emory, like you live in Georgia, go to Georgia. Or similarly, somebody goes to Texas and they're like, look, you live in Tennessee, go to Sarah Cannon, and they end up coming to me, right? So, I mean, we're pretty good at trying to make sure somebody ends up where it's most convenient for them.
Yeah, well, UT Southwestern here in Dallas and Baylor Salmon's Cancer Center are great spots to start in this area. And of course, in Houston, everybody knows about MD Anderson. I'm sure they've got all the same things going on there. And like you mentioned in Nashville, if you're in the Nashville area, Sarah Cannon Research Institute there is a great place to start as well. But I think you've given everybody some good information to take from. What other trials have you guys got going on or different research that you're into?
Yeah, so another, maybe I'll build a little bit on the idea of something of kind of a hybrid between an antibody drug conjugate and immunotherapy is something called a bispecific antibody. You guys are going to think that I'm talking about outer space here, but it's a pretty cool idea. So, antibodies, we all know what that is. That's like a trastuzumab or Herceptin. So, bispecific antibodies is essentially where you have two different sides of that molecule. And instead of just being a Herceptin and targeting HER2, you're targeting two different things. And so that can be targeting two sides of HER2, so like extracellular domain 2 and 4. That's out there for HER2 drugs. But there's also bispecifics, like there's one that targets PD-L1 and VEGF right now, that's in development for triple negative breast cancer. So this is pretty cool. So you're essentially taking an immunotherapy and then like a bevacizumab Avastin drug. Now, Avastin has a sordid history in the United States for triple negative breast cancer. We had an approval for triple negative breast cancer. It got rescinded. Controversial. We can all go back and talk about this. That happened, we had it approved when I was in fellowship. It is still approved for breast cancer in Europe. They're still giving it. But a lot of us think that this is potentially a very exciting strategy, really to boost the responses for immunotherapy and triple negative breast cancer. There's also another strategy you can do with this bispecific. So you can also have a target, and then on the other side of it have like CD3, an immune molecule. And so you can have a target that then brings in the immune system near that molecule. So instead of just relying on something like PD-1, you're binding the cancer cell with the target and then pulling that immune molecule in with the CD3. So kind of almost like a different version of CAR T that's kind of stimulating the immune system. So the bispecifics are a really exciting class. We're using this across a lot of tumor types, but I think this is an exciting class for triple negative breast cancer too, with a very science flair, I think.
That's so cool. It's awesome to see your excitement and all of this. It's like I just wonder if like sometimes you're laying in bed and you're like doing all these mathematical equations and all these like I don't know chemical symbols are flying past your head. Like I think and then you're like, oh, I had this idea. Does that ever happen? Like where you just like something kind of comes to you and you're like, oh, we should try this.
It does. It does. I think it's more common that I'm sitting in an exam room trying to explain to a patient what I want to put them on, and they're looking at me, and I'm like, I know this sounds a little bit like sci-fi, but I promise this is a real drug, and this is the rationale behind it.
That's so fun, man. I bet there's probably many moments that you've had like success stories with some of your clinical trials. Can you tell us about anyone in particular?
Yeah, I have a lot of patients I could tell you about. I have a pretty cool job that I think is different than most clinical trialists. In most institutions, the phase one clinical research is very different than kind of late phase clinical research. Just most academic institutions, that's kind of split. And at Sarah Cannon, we kind of all do it together. And so I have the opportunity of treating my kind of standard of care patients that may see me twice a year for their follow-up and I've been cured for 10 years. And then my every 3-month endocrine therapy patients, and then my patients that are just on standard chemo, and then my late phase clinical trial patients and my phase one patients, and I see all those in a given day, which also means that some of my patients kind of go in between those different phases of clinical trials or standard of care, and they stay with me instead of having to move between doctors and between trials. So I have quite a few patients on phase one clinical trials that have been on phase one clinical trials for years. And I think that's super rewarding because people just don't really think about phase one clinical trials being things that people stay on for years. I have patients that have been on triplets back when CDK4/6 inhibitors weren't FDA approved. They've been on CDK4/6 inhibitors for 6+ years, and they're still on a phase one trial, which is pretty cool. I have patients that are still on Enhertu that were on clinical trials with Enhertu, which is pretty cool. We also have some new antibody drug conjugates. I have a patient that is on a new B7H4 antibody drug conjugate, which is a new target for triple negative. And it also has a new payload. So unlike Dato, unlike trastuzumab deruxtecan and HER2, it's not a topo-1 payload. This is a different payload. And this is for triple negative breast cancer. And she has done incredibly well. She's had more than a 90% response. And she's actually decided to space out her treatments now. So she's only doing treatment every 6 weeks instead of every 3 weeks. And she's been on this trial for more than 2 years now, doing super well. So that one stands out to me as well. She's actually has lived in the United States for quite a while, but is Egyptian and has a lot of family in Egypt, and just went back to Egypt for the holidays and brought me a very cute stone pyramid, and she's very sweet. So
I love all that, man. And I guess it's just been really cool if you think about like their quality of life before and after these cutting edge treatments. Has it just been pretty miraculous watching that?
it is, and it's just, I mean, I think cancer's tough because there's so much that is unknown, and it's tough for patients because they start new drugs and they don't know how they're going to feel on this particular drug. Nobody does. I mean, you can tell, patients, this is how most people feel, right? But I mean, even when somebody goes to the drugstore and they take a Benadryl, I mean, you can tell somebody how most people feel on a Benadryl, but everybody's different, right? And so everything's a leap of faith. There's just so much that really isn't known. And then there's so much anxiety leading up to that first scan because, they just want to be one of the responders, right? And so I think it's just so rewarding when people have these, great responses, and they kind of settle back into like, okay, like I'm good. I'm going to be one of these people that is responding really well. I've had one patient that has had a great response, and she's been on a clinical trial for several years, and she decided to get remarried. And so she had a wedding, and she's
Oh,
married,
cool,
and she
man.
travels now, and she's happy. And she was like, I just never thought I was going to be at this place in my life again. Right.
Yeah.
And so seeing those moments that people didn't think they were going to have again is super rewarding, right?
I can't even imagine. I know that you guys are bringing so much hope to people year round, and I know that you're doing it right now, and even more people will see this after it's up on our YouTube channel as well. I just can't thank you enough for coming on tonight, being a part of the show this evening. Erika, it's been so cool getting to know you and chat with you and learning so much. Gosh, I'm excited. You get me all pumped up, man. Nashville, here we come. We're going to change the world.
I'm ready.
Let's do
Come
it.
to Nashville.
Heck yeah, heck yeah. Thank you so much, Erika, for being on the show tonight. I look forward to meeting you in person, and we'll be sure to spread the word about everything you're doing, okay?
Well, thanks so much for having me, and thanks to all your listeners.
Thank you so much. Have a great evening, okay?
Thank you.
Take care.